Dr. Sarjan, can you start sharing your slides? Okay, you're ready, no? Okay, good evening, everybody. Welcome to this edition of ISG K PG class. As per the popular request, we are doing the recent advances classes. We have the recent advances in gastroenterology today, and the faculty for today's session is Dr. Sojan George. We'll have another session on next Tuesday, recent advances in endoscopy by Dr. Matthew Philip, and on 31st, we have another session on hepatology that will be done by Dr. Syria Abby Phillips. Dr. Sojan is well known to all of you. He is the treasurer of ISG Kerala chapter and he is faculty of Amala Institute of Medical Sciences, Trichy. He is a senior consultant there and he took his DM from Trivandrum Medical College. And he has bagged many prizes during his student days. He has won many awards for case presentation and he also award from AIG quiz competition, I suppose. Okay, so he has a lot of laurels to his credit and he is well-read, well-knowledgeable, enthusiastic, energetic, young, but senior consultant. Okay, so over to you, Dr. Sojan, to deliver your talk. And as a house rule, please keep the video in mute fashion and as well as the audio and video, all others, please keep in mute mode. Okay.
Good evening to all. At the outset, let me thank Varghese Thomas sir for giving me this opportunity. I'm sure that this was a very wonderful opportunity, not just for the students, but for the teachers as well. We are growing together and I should very happily convey to Varghese sir that whatever efforts he is taking have all borne fruit and many students tell like they are immensely benefited from this program. So thank you so much. Thank you once again for entrusting me these topics because this motivates me to read. And just like last time, what I have done is I've gone through all the recent articles which have been published in the last few years in some of the very reputed journals like NEJM, Lancet, Gut, then American Journal of Gastroenterology, Indian Journal of Gastroenterology, and Clinical Gastroenterology and Hepatology. So I have gone through some of these articles, selected a few which I felt like was very important. But I should confess that this has been made in the mode, in an exam preparation mode. And for practitioners, this may not be very beneficial, but I have tried to do my justice by making this presentation suited for the postgraduates since they are going for their exams. So let me start. Since this is the era of COVID, I thought like I'll start with reviewing COVID-19 and GIT. As we all know, the COVID pandemic is almost dying down, but still we do not know what is in store for us. However, like COVID-19 and GIT could be an area of interest for the next few years to the examiners. And it's my responsibility to start off with COVID-19 and GIT. So COVID-19 and was, as you all know, was first noted in December 2019 in Wuhan, China, and has an incubation period of 6.4 days, with an average between 2.4 and 11.1 days. As is well known, GI manifestation include diarrhea, which is the most common symptom and is seen in around 2 to 16.5% of individuals suffering from COVID-19. Other symptoms include vomiting and abdominal pain, which can be seen among various studies. It has been reported from 10% to more than 50%. And what is striking is that close to 1/3 of patients, that is 10 to 28% of patients, have only GI symptoms and no respiratory symptoms. What is more alarming is that it may persist in anorectal swab for a mean of 11 days, even after a negative throat swab for a median period of 28 days. Now, why is it that GIT is commonly affected? As we all have reviewed over the last few months, the COVID-19 enters into a cell using two receptors. One is angiotensin converting enzyme 2 receptor and a cellular serine protease, TMPRSS2. Both of these are present in abundance in lungs but also in GIT, cholangiocytes, and liver, thereby making GIT prone for COVID-19 infection. Transmission in COVID-19 is because of, through three routes: droplet, aerosol, or contact. Now, there are 5 mechanisms which has been proposed for diarrhea in patients with COVID-19. The first one is a direct virus-mediated damage. Second one is an indirect inflammatory response to the virus. Thirdly, we know that there is significant dysbiosis. This can be attributed to 2 reasons. The first one is the drugs that we use, antibiotics or antiviral drugs that we use in COVID-19, or the virus per se can cause dysbiosis resulting in diarrhea. The fifth or the final mechanism that has been proposed to result in diarrhea in patients with COVID-19 is the disturbance of a gut-lung axis, wherein respiratory flora adversely affect the digestive system by immune regulation. So these are the 5 mechanisms of diarrhea for patients with COVID-19. The liver abnormalities will be dealt upon later on. I'm sure that that will be dealt with in the topic of recent advances in hepatology. But just to have a bird's eye view, 24 to 27% of hospitalized patients can have liver abnormalities. Majority have hepatocellular injury with modest hepatocellular injury with a value less than 500. The mechanisms proposed are mainly direct hepatocytopathic effect, a congestive hepatitis due to increased pulmonary pressure, drugs causing liver injury, and ischemic hepatitis mostly resulting from thrombosis. And it can also result in, and if you do a histopathology, you'll get microvascular steatosis with mild lobular activity. Now, an area of interest over the last few months have been COVID-19 and IBD. Now, studies have almost cleared of the concept that neither IBD nor immunosuppressors is a risk factor for COVID-19 onset. So, having IBD or being on suppressors has not shown in studies to be a risk factor for disease onset. But this has been partly attributed to the fact that patients with COVID-19 are much more careful and follow strictly the lifestyle modifications which are intended to prevent COVID-19 transmission. But once the patient contacts COVID-19 and has IBD, they are found to have among the various risk factors which are for severe disease, which is defined as patients who require ICU admission, need ventilator, or suffer mortality. In IBD, the risk factors are, just like in general population, age and comorbidities, but more specifically for IBD, disease activity. And active diseases are likely to be associated with a severe COVID-19. Current or recent use of corticosteroids, azathioprines, or a combination of anti-TNF plus azathioprine. So mainly steroids and thiopurines are the ones which are considered to be increasing the risk of severe COVID-19 in patients with IBD. Aminosalicylates have been shown in some studies to increase the risk, but this is controversial, and there is no guideline which recommend avoiding salicylate. It has been it has been advised to use salicylates with caution. Now, TNF monotherapy, anti-TNF monotherapy, anti-integrins, and anti-IL-12/23 pathway inhibitors are being definitely found to decrease the risk of severe disease, and tofacitinib has been not found to have an effect on the severity of disease. Though there are certain recent studies showing that tofacitinib may increase the risk as well. So disease reactivation occurs in close to 1/3 of patients, and this has been described mostly due to stopping medicines because of a severe COVID-19. So how do you treat a patient with COVID-19 and IBD? This is a recent paper published in Gut 2022. And what it has shown is that it depends mainly on 2 things. What is the severity of IBD and what is the severity of COVID-19? So if the IBD is mild or moderate in severity, then the major deciding factor is the presence of COVID-19. If somebody is having COVID-19, be it asymptomatic, mild COVID-19, or moderately severe COVID-19, the present recommendations are the same. You are expected to taper off corticosteroids and switch to budesonide if it is necessary. Thiopurines are supposed to be thiopurines, methotrexate, and tofacetine. All these three are supposed to be withheld. In case you plan to start a biological, it is better to wait for 2 weeks and see whether the disease is progressing to severe disease. If it is not progressing to severe disease, probably you can start biological after 2 weeks. So that is the present recommendation. So if the patient is having COVID-19 and IBD, the disease is inactive, basically you are supposed to continue salicylate, budesonide, and rectal therapies and manage with it. Now, on the other hand, if the patient has COVID-19 and if the disease is severe, if the IBD is severe, then you may have to start biologics, that to anti-TNF monotherapy. If due to financial can't start a biologic, then probably you will have prednisolone at a dose of less than 40 milligram per day. But this is again after explaining all the side effects. That is what is recommended. Now, as we all know, an acute severe colitis per se increases the risk of thrombosis. And this is true as far as COVID-19 is considered as well. So all these patients with severe COVID-19 and severe IBD, you have to start thromboprophylaxis. So let me make it clear once again. If the disease is mild to moderate or an IBD in remission, you are supposed to continue only 3 things: salicylate, budesonide, and rectal therapy as and what is required. Now, if the IBD is severe, and if you feel like the coronary, SARS is, the COVID is also severe or mild, probably the way forward would be an biological, that is anti-TNF as monotherapy. But it is always recommended to give an antithrombotic agent along with that, thromboprophylaxis along with that. The next issue is COVID vaccination in IBD. It has been found that mere presence of IBD itself decreases the response of a patient to COVID vaccination. It has been found that the response is 80% after the first dose and 97% after the second dose, while in healthy individuals, it is 97% and 100%. So even though the response is not as good as in healthy controls, it is still okay. And to give following vaccination also, it has been found that the spike in level, the increase in or the median levels of antibody against spike protein was significantly lower in IBD patients in comparison to healthy controls. Which vaccine to use? If an mRNA-based vaccine, it is found to be superior, but even adenovirus-based vaccines are also found to have efficacy, though not as much as mRNA-based therapies. Now, regarding the medications and their interaction with the vaccine, anti-TNF, anti-IL-12/23 or JAK kinase inhibitors had significantly lower median levels of antibody response to vaccination. So though they do not increase the severity of disease and may be in fact protective, they are found to decrease the immune response. And it is explainable because the COVID-19 severity is reduced because of an immune suppression, and that can result in decreased response to vaccine as well. Regarding the durability of immune response, it has been found that approximately 77% drop in antibody levels was observed after 12 weeks of vaccination, and this may prompt us to look into a possibility of an early booster dose vaccination in patients with IBD. This picture summarizes the vaccine response. On the left, you have the drugs which cause decreased response to vaccination. They include anti-TNF with immunomodulator, which has the most potent suppression of and seroconversion rate is only 81 to 100%, while anti-TNF alone causes a seroconversion rate of 93%. Corticosteroids again reduce it to 89%, and JAK inhibitors like tofacetine reduce it to 94%. On the other hand, ustekinumab, vedolizumab, thiopurine, and 5-ASA do not decrease the antibody response. And this is the latest which has come up in a recent article. Now, regarding COVID-19 and pancreas, earlier on when COVID started, it was even in our group of ISG, we had discussions of severe pancreatitis happening in patients with COVID-19 and patients presenting with pancreatitis alone. But it has been found that though pancreatic enzymes are elevated,
You have lost the audio. Dr. Sojan, are you there? We'll wait until Dr. Sojan logins. There seems to be a technical problem. Please be online. We take a couple of seconds for him to log in again. Okay, we'll generate some discussion on the topic which has been discussed so far. Dr. Robert? Dr. Robert? Okay, has anyone come across situations like serious COVID and serious IBD together and having difficulties in management aspect? Dr. Robert, Dr. Robert is a senior consultant, professor and HOD of Gastroenterology of Hamala Institute at Trichur. Dr. Robert.
And we have not initiated steroids for these patients, but we have continued steroids without much problem. Not severe COVID, mild COVID.
So the patient with the severe COVID were also on steroids, especially with the severe respiratory symptoms. And so there is a little difference of opinion. No? When patients with the COVID with the severe respiratory symptoms receive steroid, and patient along with that, if the patient has IBD, we are expected to change over to budesonide or reduce the dose.
Yes.
That information is
that is a
variance with what is being practiced. Maybe literature supports the reduction of the dose. Okay. Have you come across any situation where COVID leading to pancreatitis?
No, not in my. I don't know whether Anu has seen. I haven't seen. Or surgery.
Any other faculty? Any other faculty? Have you come across
pancreatitis, severe pancreatitis? No.
I have come across 2 instances of severe pancreatitis, very severe pancreatitis, but not actually due to COVID, but occurring within 2 weeks after vaccination. I don't know whether it is related or unrelated, but the risk factors for pancreatitis were very minimal in the patients, and the only other thing is this vaccination. I do not know how it is related. We do not know, but I think until and unless we have more papers, we will keep our fingers crossed. And what about the liver hepatitis?
That we have seen a lot of cases with elevated SGOT.
Yeah, transaminasemia was not uncommon in most of the patients, but not significant enough to cause jaundice. That is what I also thought.
That's right. And this pancreatitis, did they survive? The vaccination complication?
Yeah, this patient survived, of course. He was in the ICU, very severe situation, and survived, of course, survived. Dr. Sojan seems to have some technical problem. I do not know. I think, let me call him. Meanwhile, if anyone wants to share their information, share their ideas, any faculty member or even residents can share. Let me just call up Dr. Sojan and try to find out what's the issue.
If you come to time, you can pick.
Dr. Sojan has some technical issues for logging, but we will not cancel the class. I have asked him to send his presentation by email to me. So I will project from my side, and Dr. Sojan may be able to continue his lecture through logging through mobile phone. So let us try. Never say die attitude.
That should not be.
Sorry to be for the technical glitch. Hope I am audible right now.
Okay, Lucky, you are back.
There has been some technical glitches here last few days. I thought like it was over, but today again.
Okay, what we can do, if there's a bandwidth issue, we can switch off your video and continue with the talk.
Yes, sir. Switching off my videos.
Sorry for the disturbance. We will continue with the session. Please go ahead.
Slides visible, sir?
Yeah, visible.
So what I was speaking of was regarding the recommendation for screening before endoscopy in the post-COVID scenario. So there has been a recent AGA guideline published in September 2021, where they recommend against routine testing prior to endoscopy. However, in endoscopy standards that implement a pre-procedure testing, they recommend utilizing nucleic acid testing, either RT-PCR or lab-based NAT, and not an rapid antigen test. Now, there is a growing concern about the functional gastrointestinal diseases increasing in the post-COVID scenario. So is it just a feeling, or is there real-world evidence? So this was a paper published by Uday Ghoshal et al. In the Journal of Gastroenterology and Hepatology, volume 37 in 2022. It has been found that patients with COVID-19 had a higher probability of development of chronic bowel dysfunction to the tune of 5 to 8%, dyspeptic symptoms to the tune of 3%, and their overlap in 5% within the first 3 months of follow-up, and IBS diarrhea in particular over a 6 months follow-up. Now, what are the risk factors for developing a functional gastrointestinal dyspepsia post-COVID? Patients who are symptomatic had a higher risk. Patients who had GI symptoms during their acute COVID-19 had a higher risk. And other risk factors were presence of anosmia, ectasia, psychological comorbidities, presence of IBS or dyspeptic symptoms prior to the disease onset. So all of these were considered as risk factors for post-COVID functional gastrointestinal diseases. Now moving over to the other topics. With that, I completed some of the recent papers which have come regarding COVID-19 and GIT. Now we are moving over to GI bleed.
Interruption. There was a mention, it was shown CBD in 2 places in your last slide. Can you just go to the last slide?
Chronic bowel dysfunction.
So,
and that is what has been coined in that paper by Dr. Uday Ghoshal.
Chronic bowel dysfunction.
Yes, sir. Basically, they mean dyspeptic symptoms, gastroparesis, all these are clubbed
Okay, multiple chronic symptoms. Okay.
Yes, any bowel disorder without an obvious underlying organic disease has been described as CBD.
Okay, thank you. Please go ahead.
Right. So next is GI bleed. As you all would be aware, and as you would have gone through this paper in New England Journal of Medicine, published in April 2, 2020. This was a landmark paper, and there was always a question regarding timing of endoscopy. So what they did in this study was they have selected 516 patients who presented to the emergency department with GI bleed. They classified or they randomized these patients into 2 groups. One group of patients underwent endoscopy within 6 hours of admission, and the other group underwent endoscopy between 6 to 24 hours of admission after stabilization. It was interesting to note in this paper that the primary endpoint of death within 30 days, a rebleeding, a need for a salvage procedure like surgical treatment or angiographic embolization, and ICU admission were all higher in the urgent endoscopy group. That is the group who underwent endoscopy within 6 hours. And hence it was recommended that ideal timing of endoscopy following a GI bleed would be 6 to 24 hours after admission. But when I went through this paper, I found that they have not included patients who were hemodynamically unstable. So that would probably be a limitation of this study. And probably if you include such patients as well, the results may have been slightly different. So in patients with acute upper GI bleeding who were at high risk for further bleeding or death, endoscopy performed within 6 hours of gastroenterology consultation was not associated with the lower 30-day mortality than endoscopy performed between 6 to 24 hours of consultation. This was a non-inferiority trial and hence the result. Now, there has been multiple patients presenting with bleeding in the setting of antithrombotics being used. So we have a recent publication in American Journal of Gastroenterology, which is a guideline, again, a guideline for patients presenting with bleeding in the setting of an antithrombotic use. Majority of the things are not very different, but it is important to remember what are the procedures which are associated with a high bleeding risk and a low bleeding risk. Interestingly, polypectomy of polyps more than 1 centimeter, peg placement, ERCP with sphincterotomy. Without sphincterotomy was low risk, but with sphincterotomy is high risk. EMR, EUS with FNA, endoscopic hemostasis except APC, RFA, POEM, banding, therapeutic balloon-assisted endoscopy, tumor ablation, cystogastrostomy, ambulatory resection were all considered as high risk procedures. But it was interesting to note that ERCP without sphincterotomy, polypectomy less than 1 centimeter, APC, and clipping were all considered as low risk procedures as was expected. So it is remembered to know this for your exam purpose. And from the cardiac side, a high risk case was considered as any mitral valve, any mitral valve prosthesis, any caged ball valve prosthesis, or a recent stroke or TIA in the last 3 months. While a bileaflet aortic valve prosthesis, congestive cardiac failure, history of coronary artery disease were all considered as low risk conditions. Mere presence of aortic valve prosthesis in the absence of atrial fibrillation was a low risk case. In patients with atrial fibrillation, CHADS2 score was calculated, and if the CHADS2 score, this is the score for risk of thrombosis in patients with this is actually one of the risk stratification schema that can help to determine the 1-year risk of an ischemic stroke in a non-anticoagulated patient with non-valvular AF. So if the score was 5 or above, it was considered as a high risk condition. And recent thromboembolism within 3 months was also considered as a high risk condition. If the patient has a thrombophilic condition, that was again high risk. So it was on the basis of this, if you look at this paper, there were not many positive recommendations. They do not recommend for the use of a FFP. They do not recommend the use of idarumumab, which is an anti-dot. So all those are negative recommendations. What I found interesting was the classification into low risk procedures, low bleeding risk procedures, and increased thrombotic conditions. So this is something which postgraduates should be remembering. Coming to esophageal diseases, the most important thing that I would again stress is functional luminal imaging probe. Actually, last time when I was discussing this topic, when it came to the session that we had discussed this topic, and it was very heartening to say that this question was again asked in the last year's question paper, and it was well answered by most of the students, most of our students. So this is functional luminal imaging probe is actually an FDA approved novel device that measures 2 things. It measures the luminal cross-sectional area and the pressure in the esophagus by utilizing planimetry. Now what it does is, I will go to the next slide and show you that. This contains a catheter which has an 8 centimeter area where there are 16 impedance planimetry sensors located at 5 millimeter intervals. And it has a balloon, which is a high compliance balloon, and it is distended to measure the impedance. Based on this test, actually this is how the result will be. In flip 1, you got a topographic image, while this will be the, on the right, you could see a flip 2 panometry that will be available. What are the indications for this procedure? Achalasia, it is helpful in diagnosis and assess the efficacy of the therapeutic intervention that you have done. In patients with GRD, it is helpful to tailor the fundoplication, but especially when done intraoperatively. But there is limited data for its use as use for the diagnosis of GRD. In patients with eosinophilic esophagitis, you often see some strictured areas or some constrictions in the esophagus. FLIP helps us to assess whether it is a fibrostenotic stricture or a remodeling of the esophagus. In patients with stricture, it helps in measuring the cross-sectional area of the pharyngo-esophageal junction and to guide endoscopic dilatation in patients with esophageal stricture. So these are the indications. It is useful in 4 conditions: eclasia, GRD, eosinophilic esophagitis, and esophageal strictures. However, there are certain limitations for FLIP as well. It is costly, as we all know. There is lack of expertise, mainly in our area, and there is very limited data regarding the efficacy. But it is an upcoming modality, and often in exams they ask about one of the new investigation, and I think like this can again be asked this year as well. Now we have heard about Chicago 3 classification, and there has been a recent Chicago 4 classification. The major differences in Chicago 4 classification are 2. Now in Chicago 3, they had classified it into severe disorders and mild disorders. So major disorders and minor disorders. Now in Chicago 4, the classification has become different. They have classified the differences into disorders of EJJ outflow, that is esophagogastric junction outflow, or disorders of peristalsis. Esophagogastric junction outflow obstructions include eclasia 1, 2, 3, and esophagogastric junction outlet obstruction, while in disorders of peristalsis, they have included absent contractility, diffuse esophageal spasm, hypercontractile esophagus, and ineffective esophageal motility. So how do they classify it? They look at the IRP initially, and if the integrated relaxation pressure is high, they looked at peristalsis. If there was failure of peristalsis and there was absence of panesophageal pressurization, that is PEP, it was classified as eclasia 1. If there was failure of peristalsis, but in the presence of panesophageal pressurization, it was eclasia 2. And if there was premature contractions, failed peristalsis, plus or minus panesophageal pressurization, it was eclasia 3. So that is regarding the diagnosis of eclasia as per Chicago 4. Now, another major difference between Chicago 3 and Chicago 4 is that in Chicago 3 classification, they had only recommended performing 10 bed swallows in the primary position. But in Chicago 4, they recommend doing it if the results are inconclusive in the lying position, to do it in the secondary position, that is a sitting position, and also using solid state swallows. Now, it is often known that we all know about the risk of eclasia. Eclasia can be a common common case for your examination or viva. So we often speak about the carcinoma risk in eclasia, but what is the evidence? So there are 2 interesting papers in this regard. The first one was from Italy, published in American Journal of Gastroenterology, February 2021, where 566 patients were followed up for a mean of 15.5 years, and it was seen that 20 patients developed cancer, of which the predominant cancer was squamous cell carcinoma, and 5 patients had adenocarcinoma. So the risk of esophageal cancer was 104.2, and it was higher in men than women, and the annual incidence rate was close to 0.24%. Now, there was another paper which was published in 2021 Journal of Gastroenterology, which looked at a similar finding, and they followed up 2,714 Japanese patients. And they found that the incidence of esophageal cancers was 0.078 in total and 0.28 per 100 person years. Long history of eclasia, advanced age, male sex, and regular alcohol consumption were statistically significant risk factors. All were histologically diagnosed as squamous cell carcinomas, and in this follow-up, there were no adenocarcinomas at all. Now, this is an American College of Gastroenterology guideline regarding the management of eclasia. After a diagnosis using upper endoscopy, which comes as normal or has some resistance while passing GE junction, and a manometry or a FLIP, achalasia has been classified into type 1, type 2, or type 3. In type 1 or 2, all three modalities can be useful. So it can be either pneumatic dilatation, laparoscopic Heller's myotomy, and or POEM. But it has been found in various papers that POEM and laparoscopic Heller's myotomy are the best modalities to use. But in type 3 achalasia, POEM scores over Heller's myotomy. In patients who are unfit, botulinum toxin or smooth muscle relaxants are the way forward. So the key difference here was that there were more and more recommendation for use of POEM in type 3 achalasia, while the benefit was found to be equal in cases of type 1 and type 2 as far as laparoscopic Heller's or POEM was considered. POEM has the advantages of early return to normalcy, less hospital stay, and post-operative and a better post-operative recovery, but with the flip side of having increased regurgitation, and that has been found to be the major risk factor. There has been studies regarding fundoplication along with POEM, but the results are still not very convincing. So in type 1 and type 2 achalasia, laparoscopic Heller's myotomy and POEM has almost equal efficacy. In type 3, POEM has got better efficacy as per and as recommended by the American College of Gastroenterology guideline. Now, PPIs and H. pylori. Again, vonoprazan is something which you should all be, this is something which we have all heard over the last few years. It is still to make its entry into Indian market, but has been found to be very promising in studies conducted in Japan, where it has been discovered and is being used widely. This was a question in the last year's question paper, and vonoprazan is actually a potassium competitive acid blocker. It inhibits acid secretion by competitively blocking the availability of potassium to hydrogen potassium ATPase. So the mechanism of action is competitive blockage of binding of potassium to hydrogen potassium ATPase. The advantages is that it is acid stable and is rapidly absorbed either in the fasting stage or in the fed stage. So it is unaffected by food intake. The half-life is approximately 7.7 hours. It has a high pKa, so it accumulates faster and well in the canalicular space, where it competitively inhibits active and resting proton pumps. No dosage recommended adjustments are needed for renal or liver disease. That is another advantage. It is not found to have an infection, but the negative side is that it can have some interaction between cytochrome P2B6 and cytochrome P3A45, can result in drug interaction, especially with clarithromycin. Advantages over PPI therapy include a long half-life and no relation to food intake, with a higher efficacy as well. So next, we are moving over to a question of mass eradication of H. pylori in patients who do not have symptoms. So this was an interesting paper which came from Matsu Islands, which was in Taiwan. So what they have done is that they found that the incidence of gastric cancer and H. pylori was very high in them. So they educated all patients between 2004 and 2018. This was a high-risk Taiwanese population, age 30 years or older, and patients who were urea breath test positive were educated and given eradication of H. pylori. After 6 rounds of mass screening and eradication, it was found that the coverage rate reached 85.5%. The prevalence of H. pylori fell from 64.2 to 15%, showing that the treatment and education that they gave was effective. But did it translate to an improvement in the cancer risk and decrease in atrophic gastritis and intestinal metaplasia? It was found that the gastric cancer incidence during this period also fell down from 53% to 25%, showing that even if the patient is asymptomatic, it may be beneficial to treat these patients with H. pylori eradication. What are the newer treatments for H. pylori? One is a rifabutin-based triple therapy. So you combine either a PPI, rifabutin plus clarithromycin or amoxicillin. Now, there have been many studies showing its efficacy as a second-line treatment in patients who have already failed a treatment with the classical regimes. And the efficacy has been found to be close to 73 to 79%. But how far it can be used in tuberculosis prevalent regions like India is still a matter of debate, and probably we require more studies from India in this regard. But one regime which has shown promise is a combination of vonoprazan and amoxicillin. Here you give vonoprazan and amoxicillin at a dose of 750 milligram 4 times a day. So making it a cumulative dose of 3 grams. There have been studies earlier regarding a combination of a dual amoxicillin regime in the PPI plus a high dose amoxicillin regime, but it has not stood the test of time. And what is recommended right now, what is coming up right now, is a combination of vonoprazan plus amoxicillin. Probably we will have to wait till the jury is finally out. There has been a recent ACG guideline, so we are moving on to the irritable bowel syndrome, and probably there are 3 drugs which I found could be asked in your exams, and they include linaclotide and plecantide, which are basically guanylate cyclase C inhibitors. By activators. So by activating guanylate cyclase C, it increases the intestinal fluid secretion and peristalsis. But it has an additional benefit of reduced activation of the pain neurons or visceral nociceptive neurons as well. So in patients with irritable bowel syndrome, constipation type, this would be an ideal agent. It will decrease constipation by being a secretagogue and increasing intestinal peristalsis. It will also help in decreasing the pain by reduced activation of visceral nociceptive neurons. It is effective, safe, and well tolerated, and it is more effective than placebo for improving overall symptoms. But the adverse effect, as expected here, would be diarrhea, and this would be an agent to be used in patients with irritable bowel syndrome, constipation type once it is available. Eluxadolin has been recommended as a newer pain reliever in patients with IBS. It is a peripherally acting mixed mu and kappa opioid receptor agonist. By acting on opioid receptor, it decreases the nociception and is approved for the treatment of men and women with irritable bowel syndrome diarrheal type. The recommended dose is 100 milligram orally. Efficacy has been found to be 27% compared versus 16.7% compared to placebo, and the number needed to treat is 10 for 1 to 12 weeks, and by 1 to 26 weeks it was 9. The adverse effect is constipation, and hence that is the reason why it has been recommended for patients with IBS diarrhea. The side effects include nausea, cardiac events, sphincter of OD spasm, and pancreatitis, but all of these are found to be very rare. The contraindication for its use is severe hepatic impairment. The third molecule, which has been recommended in the guideline and maybe a question in recent advances paper, is tenapanor. Tenapanor is a potent inhibitor of the sodium hydrogen exchanger 3, localized in the apical membrane of intestinal epithelial cells. Now, this is mainly concerned with uptake of sodium ions and water. So when you give it, it will help to relieve the constipation. It does not have any benefit in nociception, unlike the guanylate cyclase receptors which I mentioned earlier, but it is found to be effective in the treatment of irritable bowel syndrome constipation type. The non-systemic action of tenapanor constitutes a significant advantage and reduces the side effects. The side effects, however, include diarrhea, abdominal distension, flatulence, and dizziness. So in IBS, you need to know 3 new molecules: eluxadolin, tenapanor, and guanylate cyclase inhibitors like linaclotide and plecantide. In the miscellaneous section, I thought like I would be dealing with teduglutide, which is a useful drug in short bowel syndrome. Teduglutide is a recombinant degradation resistant longer acting GLP-2 analog. It is safe and well tolerated. It responds well compared to placebo. It has a response rate of 63% versus 30% in placebo. It reduces the diarrhea. It reduces the requirement of total parenteral nutrition. And on continued use, its benefit was found to be improving or increasing. It is now approved for both adult and pediatric patients with short bowel syndrome as an aid to parenteral nutrition weaning. So tenuglutide is, it was there later on, but it is recently approved and hence a point of importance. Now, moving over to the gut bacterial side, gut floral side. This has always been a topic of recent interest. We know about probiotics, which are live bacteria given to the gut to alter the GI flora favorably. You know about prebiotics, which are actually molecules which promote the growth of certain bacteria like oligosaccharides, galacto-oligosaccharides, fructo-oligosaccharides, and the like. Then came fecal microbiota transplantation. I'm sure that AB will be touching upon it as he's a expert in the field. Now it has moved on further, and there have been three new things which has come up. One is paraprobiotic, and the other is postbiotic. Now, what is paraprobiotic? This actually is a term which refers to non-viable probiotics. So they are either inactivated or killed bacteria, and it has been found that even while supplementing this killed bacteria, it can be beneficial to the organism. On the other hand, postbiotics actually include products obtained from the metabolic processes of live bacteria or released after bacterial lysis. So these are the metabolic products of bacteria. They are extracted from the bacteria either while they are live or after their that is after lysis. And these include cell surface proteins, cell-free supernatrins, cell lysates, bacteriocytes, enzymes such as glutathione peroxidase, and superoxide dismutase. So all these products of bacteria can be extracted and they can be given, and that is what is called as postbiotics. Now there is a recent term which has come up, which is psychobiotics. Here, this is more in the neurology side. Here, live bacteria, when ingested in appropriate amounts, might confer a mental health benefit by affecting microbiota of the host organism. So these group of bacteria, mainly lactobacilli group and bifidobacterium group, these are the bacteria which are given to alter the mental state of an individual beneficially, favorably, and is more often used in patients with depression. This set of bacteria is called as psychobiotics. Now, going over to colon cancer. ISG clinical guidelines on colorectal cancer 2021 is a must read for all our postgraduates. And I will tell you the key takeaway points. Colorectal cancer is recommended, screening is recommended between 50 to 75 years. In patients with average risk, it is found to be between 45 to 49 years. And in patients with high risk, that is, if you have a first degree relative less than 60 years, or a colorectal carcinoma or advanced polyp in more than 2 first degree relatives at any age, they should be considered as high risk individuals. And there, the recommendation is to start screening at the age of 40 or 10 years before the index case or the youngest index case. So normal population 50 to 75 years, average risk individuals who are having a one family history in a one family first degree relative after the age of 60 years, it is recommended to just a second. It is so in an average risk individual, it is recommended at the age of 45 to 49 years. So average risk is family history of colorectal carcinoma, but not belonging to the high risk group. And in high risk group, which is first degree relative less than 60 years, or presence of colorectal carcinoma or advanced polyp in more than 2 first degree relatives. So there it is 40 years or 10 years before the youngest relative. How to screen it? Use either a multi-target stool DNA test every 3 years, or sigmoidoscopy every 5 to 10 years, or a CT colonography, colon capsule, or colonoscopy every 5 years. So who can screen it? Who can do the surveillance? Basically, a colonoscopist should satisfy 3 criteria. He should have an adenoma detection rate of more than 25%. He should have a cecal intubation rate of more than 95%, and he should have a withdrawal time of more than 6 minutes. So these are the key recommendations in this patients as per the ISG clinical guidelines for colorectal screening. Now, this is an interesting paper which tells you regarding the follow-up of patients with a history of colonoscopy for colon cancer surveillance. This is frequently asked in your examinations, and hence I thought like I would be touching upon this paper as well. If you do a surveillance colonoscopy and find that it is either normal or has a few hyperplastic polyp, the next colonoscopy is recommended only at 10 years. If you have 1 to 2 adenomas less than 10 millimeter, it is between 7 to 10 years. 1 to 2 serrated sessile polyps less than 10 millimeter, it is 5 to 10 years. And more than 3 adenomas or 3 to 4 adenomas, more than 3, it is 3 to 4 adenomas or 3 to 4 sessile polyps, it is 3 to 5 years. If there are more than 5 to 10 adenomas or serrated sessile polyps, or an adenoma of advanced dysplasia, which is either a large polyp more than 1 centimeter, presence of dysplasia, or presence of a tubular villus adenoma, if you have removed it, the next colonoscopy should be done at 3 years. And if there are more than 10 adenomas, next colonoscopy is recommended at 1 year. So more than 10 adenomas, 1 year. 5 to 10 adenomas or AAPs, that is adenomas of advanced pathology, it is 3 years. Less than that, the recommendation is given as I have shown in the slide. Multi-target stool DNA test is something which can be asked this year because this is actually an investigation. Now, as we all know, the colon cancers are found to have cells, neoplastic colonocytes, which are showing an increased proliferation but less cohesion. So that these cells tend to get shed into the stools. So by studying the stools and assessing it by an array of mutations like mutant KRAS, methylated BMP3, and methylated NDRG4, and a fit for hemoglobin, we take the stool of the patient, process it, and analyze it through an automated assay system. You don't get a particular value in this, but the test is reported as positive or negative. Now, compared to the fecal immunotesting, which was the best screening test available, this was found to have a higher sensitivity, but a lower specificity. Pardon for the mistake, like it is lower specificity and higher sensitivity. But for a screening test, you know, like a test is ideal if it has a higher sensitivity. So if you look at the clinical application, this is recommended for screening of patients with average risk colon cancer and should not be a replacement for colonoscopy. So it is not recommended for patients with ongoing GI bleed, personal history of colorectal cancer on follow-up, colorectal adenomas with a history of a patient with a history of colorectal adenomas or IBD, high-risk patients, which I mentioned earlier, that is colorectal carcinoma in an individual less than 60 years or 2 or more first-degree relatives at any age, or heritable cancer syndrome. In these patients, actually colonoscopy is recommended and not multi-target stool DNA testing. It is recommended once in every 3 years, and follow-up with colonoscopy is needed if the stool test is positive. It is not a replacement for diagnostic or surveillance colonoscopy, as I mentioned earlier, and asymptomatic individuals with a positive multi-target stool DNA test and a negative high colonoscopy does not need additional testing. As I said, the specificity is low. So once you confirm that there is no malignancy in colonoscopy, you can stop with that. Now moving over to the most important part of my talk, that is regarding IBD. And this is where most of the questions will come up in recent advances in gastroenterology. There are two types of molecules or two types of agents which you can use to treat IBD. They can be classified into biologics or small molecules. The classical examples for small molecules are steroids and thiopurines, but there are some new small molecules which are coming. So biologics, the classical example is anti-TNFs. So it is essential to know what the difference between a biologic and a small molecule is. A biologic is a protein. So it is an antibody, which is either a chimeric molecule or a humanized molecule or a human antibody. On the other hand, the small molecules are chemicals. Most of the biologicals has to be administered in the parenteral route, at least as of now, while small molecules are mostly administered through the oral route. Now, biologicals, the same molecule like infliximab and its biosimilar can be manufactured by various routes. So they have a variable 3D structure, while in small molecule, the structure is well defined. Biologicals are usually catabolized while being a protein, while small molecules are often metabolized in kidney and liver, and hence it can have its dosage adjustment requirements in patients. Mechanism of action is either blocking or depletion as it is an antibody, while in small molecule, it is most often an enzyme inhibition. But the major difference between biologic and small molecule is that the cost of production. The cost of the molecule will be much more higher in patients with biologics compared to small molecules. So what exactly is a biosimilar? Biologic agents are highly similar to an existing FDA-approved reference biologic. So whenever there is a biologic which is newly discovered, actually it is called as an innovator molecule. But most often these molecules are patented by the company which produces it. So other farmers try to produce a similar product through a different route. So it is almost like whiskey and rum. I would always use this analogy. Both are not exactly the same, but has the same effect. So similar is the case with biosimilars as well. So these are molecule which amino acid sequence, which has the same amino acid sequence. So the amino acid sequence of the active agent should be identical in the innovator molecule as well as the biosimilar. But there may be a subtle difference in glycosylation as a result of its production using a different cell line. Now, this subtle difference would result in a different pharmacology and potential immunogenicity. So the antibody response to a biological may not be exactly the same as that of an innovator molecule. So can a patient who is on innovator molecule be switched off to biosimilar? There has been a no-switch trial which showed equal efficacy while switching to biosimilars. So to start off, we are discussing about biologicals rather than small molecules. So we all know about infliximab, adalimumab, certolizumab, and golimumab. So I will not be discussing anything about it because they are no longer new. So the recent molecules which have come up include ustekinumab, vedolizumab, natalizumab, and ertolizumab. So I'll be discussing mainly about vedolizumab and ustekinumab because they are the most likely questions in your DCS paper. So vedolizumab is actually an anti-integrin. Now, once a T cell is activated, it needs to reach the area, especially the bowel, to cause an inflammation. For this, there are two molecules which help. There is an alpha 4 beta 7 integrin on the surface of the T cell, and there is a MADCAM molecule on the endothelium, both of which binds, thereby causing the migration of T cell into the site of inflammation. So by blocking either the alpha 4 beta 7 integrin or the anti-MADCAM, actually you can prevent the T cell or the activated T cell from reaching the site, thereby decreasing the injury. And that is how these molecules act. So vedolizumab is an anti-integrin, a humanized IgG1 monoclonal antibody against alpha-4 beta-7. For easy remembrance, if you do not know whether it is humanized or human or chimeric, just look at the name. If it contains X and I, as in infliximab, it is a chimeric molecule. If it contains Zumab, ZU, it is a humanized molecule. And if it is UMAB, UMAB, it is actually a human molecule. So this is an anti-integrin, a humanized IgG1 monoclonal antibody against alpha-4 beta-7. But the major advantage here is that it is gut specific and can be given in a fixed dose. So it is not a body weight based dosing, it is a fixed dose of 300 mg. It has been approved for the induction and maintenance of both ulcerative colitis and Crohn's disease. It is a first-line biologic in ulcerative colitis, especially in patients who are at risk of infections and malignancies. It is gut specific, has got very little side effects. It does not increase the risk of tuberculosis or other opportunistic infections and malignancies. And hence, in patients who are prone to this, as in cases of elderly population, this may be an ideal agent to use. It has an excellent safety profile due to its gut specificity and has minimal adverse effect in the form of nasopharyngitis and sinusitis. But the major problem here would be the cause. So what is the evidence? The evidence here is mainly from the trials. I am not going into the specifics of the trials, but the trial which was used, which showed its efficacy in Crohn's disease was Gemini 2, and in ulcerative colitis, it was Gemini 1. Now, one problem with this molecule, even though it is a very good molecule with excellent efficacy and very little side effects, is the fact that it takes some time to act. So in patients with acute severe colitis, probably you may need to give either give an additional treatment with steroid or cyclosporine because it takes some time to act. But in patients with mild to moderate severity UC, this would be a very good agent to use. Next is ustekinumab. It is UMAB, so it is a humanized IgG. It is a human IgG antibody. This acts against the P40 protein subunit, which is found in interleukin 12 and 23. So it acts by blocking the action, by blocking IL-12 and IL-23 binding to its receptor, thereby resulting in its benefits. It is approved for the treatment of Crohn's disease and recently ulcerative colitis. It is given at a fixed dose of 90 milligram subcutaneous injection every 8 weeks after an initial weight-based IV infusion. But as I said earlier, it blocks both IL-12 and IL-23, but the benefit is mainly because of IL-23. That is a Th17 response. So what are the trials? There are basically 3 trials. The first 2 were the Unity 1 and Unity 2. Unity 1 included patients who had a failure to anti-TNF. Unity 2, on the other hand, was more broad. It included all patients who failed conventional therapy. So it can be a failure to steroids as well. As expected, the effect was much more significant in the Unity 2 trial, thereby it being recommended as a second-line therapy. It was told that an early use may be more beneficial. Now, then came the IM Unity trial, which was actually a trial which looked at the efficacy of ustekinumab in its maintenance of patients with ulcerative colitis. And it was found that in all these populations, it responded well compared to placebo. The clinical response rate was 33.7% in Unity 1. It was 55.5% in Unity 2. And patients at week 65 had a close to 1/3 response. Even for maintenance, the response rate was good with 53.1% response in the ustekinumab group compared to 35.9% in the plasma group. This was a result of IM Unity trial. So at least you need to remember as to which all conditions it is useful. It is useful in both Crohn's disease and ulcerative colitis, both for induction of remission as well as for maintenance. And the trial is mainly Unity trial, Unity 1, 2, and IM Unity. Is it effective in ulcerative colitis? Earlier on, the results were not that good until this trial came, which is called as a unified trial. So here, this was a multi-center double-blind trial for patients with ulcerative colitis, moderate to severe severity. 961 patients were included, and it was found that it achieved remission in close to 15.6% at week 8, and when the at 44 weeks, the response was 38.4 weeks. So it was more effective than placebo, but we need more trials in this regard. So this is a look at all the agents. Just to tell you the names of the trials. Infliximab, as we all know, the trials were Accent 1 and Accent 2 and so on. Adalimumab, it was a CHARM trials. Sotolimonab, it was a PRECISE trials. Natalizumab is no longer used. Natalizumab is no longer used because it has a high risk of progressive multifocal leukoencephalopathy, because it can prevent the anti-integrins in the neurology level as well. So natalizumab is no longer used. Vedolizumab, it is mainly Gemini 1 and Gemini 2 trials. Ustekinumab, it was Unity 1, Unity 2, and IM Unity trials. Now, regarding biologicals in ulcerative colitis, these are the trials. Infliximab, it was Act 1 and Act 2. Adalimumab, it was Ultra trials in ulcerative colitis. Golimumab, it was Pursue trials. And in Vedolizumab, it was Gemini 1 and Gemini 1 trials in Vedolizumab. This is just to tell you regarding the names of the trials, because towards the when you are discussing about the biologicals, often may be asked as to what trial showed the benefit, and these are the landmark trials which showed the benefit. Now, another major question that was raised is, especially in the Indian scenario, is can you discontinue anti-TNF therapy? As we all know, many of our patients have financial constraints and often ask us whether anti-TNF can be withdrawn. Do we have any data as to what happens in these patients? So when the anti-TNF was withdrawn due to various reasons, the major causes here was either financial burden or tuberculosis reactivation. This was a paper by Vineet Ahuja et al. From All India Institute of Medical Sciences, a very good paper. And in this case, in 45 patients, that is the anti-TNF was withdrawn, of whom 33 were in clinical remission. So that is the main thing that we need to look at. In patients with clinical remission, how many of them would go in for a relapse once the anti-TNF is withdrawn? So over a median follow-up of 26 months, 15 patients of this 33, that is 45.5%, relapsed. But when they relapsed, they responded to antibiotics, steroids, or anti-TNF agents. Only 3 required surgery. So that will help us to tell regarding the prognosis in patients with anti-TNF. If you are stopping it, close to 50% or 45.5% as per this paper to be exact, 45.5% of patients will relapse. Most of them would respond to a second challenge with an anti-TNF agent, while 3 patients among this group of 26 had a required surgery. Going over to the small molecules in IBD, I feel like this would be the last part of my session, but it is actually something which is very important for your exams. You have the major group which has come up over the last few years is the JAK-STAT inhibitors. So JAK-STAT inhibitors or Janus kinases are molecules which act as the final step of inflammation for many of the interleukins. So if you block Janus kinase pathway, you can prevent transcription and by inhibition of the STAT pathway. I'll go out to the next slide and make it more clear. So the indication of newer small molecules of treatment are the same for whichever molecule it is. So you need to remember these indications. It is indicated for corticosteroid failure, biological failure, as a combination therapy with various regimes. For extraintestinal manifestations, these are found to be very effective. And it is also effective in stop-start therapy, unlike an infliximab. Just to make clear what stop-start therapy is, the major concern regarding biologics is that once you stop therapy, and if you have to restart it again, there is a likelihood of antibodies being developed and a failure of biology. But in case of steroids, as we all notice that it can be given intermittently whenever the patient has a relapse. This is because it is a chemical and antibodies are not formed against it. The same benefit happens to these molecules as well. So you can use these regimes intermittently when the patients have a flare. Now, additional benefit of this small molecule is inhibition of liver fibrosis, which is reported in patients with IBD and could be an additional beneficial effect. So tofacitinib is the landmark molecule, and this could be a question in recent advances. So this was the first of newer small molecule agents for the treatment of chronic inflammatory disorders. Now it is a pan-Janus kinase inhibitor. There are 3 Janus kinase inhibitors, so JAK1, JAK2, and JAK3. This is a pan-JAK inhibitor, but it has more effect against JAK1 and JAK3. This is approved for patients with ulcerative colitis on the basis of 3 trials, Octave 1, Octave 2, and Octave 3. It is effective for patients with failed response to conventional or anti-TNF-alpha therapy, and it is unaffected by age, sex, body weight, or disease severity. But the side effects are a major cause for concern in patients with tofacitinib. Herpes zoster infection is commonly seen in patients who have been started on tofacitinib, and the incidence rate was found to be 2.1. Dyslipidemia, sudden death from cardiovascular disease, and increased incidence of thromboembolic events were reported in a study where tofacitinib was used for rheumatoid arthritis and hence was considered to be a major side effect of this. But it was found that this study side effects happen more often in patients more than 65 years of age who received more than 10 milligram of tofacitinib twice a day and had one cardiovascular risk factor. So in this set of patients, there is an increased risk of dyslipidemia, sudden death from cardiovascular disease, and increased incidence of thromboembolic events. And it is not safe in pregnancy as it is fratricidal and teratogenic in animals. The other JAK inhibitors are basically filgotinib and upadacitinib. It is difficult to remember the names, but what you need to remember is filgotinib is the JAK inhibitor which is effective in Crohn's disease. The trial is basically Filstroy study, and a phase 3 trial is a selection trial. Another difference from tofacitinib, it is a selective JAK1 inhibitor. So tofacitinib was pan-JAK inhibitor with preferential action against JAK1 and JAK3. Filgotinib is JAK1 inhibitor, and upadacitinib is also JAK1 inhibitor. And the trial is studied. So JAK inhibitor, if a question is asked, you need to tell the indications. You need to tell the mechanism of inhibition, mechanism of action, which is mainly inhibition of the Janus kinase pathway, which is mainly involved in transduction and transcription of molecules, which is the final pathway of action of most of the interleukins. Now, just to have a look at adverse effects of various agents which are used for all and biologicals, that is infliximab, adalimumab, and golimumab, the side effects are mainly congestive cardiac failure, multiple sclerosis, malignancies, and infections. For vedolizumab is actually considered to be a very safe molecule and has very little significant adverse effect. The main side effect is nasopharyngitis. Ustekinumab again has no black box warning, but it should be used with cautions in patients with TB as it can result in a reactivation. Tofacitinib, the side effects include infections, malignancies, and thromboembolism and dyslipidemia. Ozanimod is the final molecule which I will be dealing with in IBD, and this is actually a sphingosine 1 phosphate receptor modulator. Actually, when there is inflammation, sphingosine 1 phosphate receptor is activated. Once it is activated, the lymphocytes, which are located in the lymph node, are released into circulation, and then it reaches the site where it causes injury. Now, this lymphocyte mobilization is blocked once you are blocking sphingosine 1-phosphate. So the classical trial for ozanimod was Touchstone UC trial and a phase 3 True North trial. Now it has been approved for induction and maintenance of remission in adult patients with moderate or severely active ulcerative colitis. The adverse effects include opportunistic infection, but the major side effects which you have to remember here is bradycardia and AV conduction delays, liver injury, and macular edema. So ozanimod is another newly approved, FDA-approved molecule for treatment in ulcerative colitis. A set of recent papers in Lancet have all focused on IBD, and an editorial was written in this regard. So these papers looked at the efficacy of self-expandable metal stents versus balloon dilatation, which is called as a broad dilate study, in patients with Crohn's disease. So all patients with Crohn's disease who presented with intestinal obstruction were randomized into two groups. And in one group, you had a CRE balloon dilatation. And in the other group, you used a 20 millimeter fully covered self-expanding metal stent. Which one was beneficial? 80 patients were included, and it was found that the better results happened in the balloon dilatation group compared with a response rate of 80% compared to only 51% response in the fully covered self-expanding metallic stent group. And it was found that as a result of the study, it was concluded that endoscopic balloon dilatation is a more effective treatment modality than fully covered self-expanding metal stent in patients with chronic Crohn's disease and strictures. This is another paper which looked at the medical management of strictures in IBD. They used two regimes: intensive drug therapy regime, where 160 milligram per week adalimumab was given every week for 4 weeks, and then 40 mg every 2 weeks. And in the second group, you use the classic regime, that is 160 followed by 80 mg after 4 weeks, after 2 weeks, and then every 2 weeks 40 mg. It was found that though there was marginally better response in the intensive group, the results were not statistically significant. Pancreas, since I was advised to touch upon the recent advances in pancreas, when I went through the papers, I found that most of the recent advances in pancreas is in connection with ERCP, spyglass, or EUS. So I'm sure that Matthew Phillips sir will be dealing with all these topics later on in his session. So I will be limiting myself to a new concept of ESWL pancreatitis. As we all know, this ESWL is more often used in patients with chronic pancreatitis recently with difficult to remove stones. And it has been found that 11% of patients post ESWL develop pancreatitis. The risk factors for ESWL pancreatitis include steatorrhea, multiple stones, stones located in the head combined with body and tail. So head stones were more important, and these were independent factors for post-ESWL pancreatitis. And the main method for prevention of ESWL pancreatitis was rectal indomethacin, just like in the case of post-RCT pancreatitis. Before I conclude, I would ask postgraduates to read the following as well. There has been many papers coming up recently in artificial intelligence, machine learning, or deep learning. Basically, whatever diagnosis is needed, the image is taken, converted to a language of numbers, fed to a computer system, which analyzes the picture and ensures whether the diagnosis is fitting or not. So you need to know about the role of artificial intelligence in gastroenterology. Liquid biopsy is again taking a blood sample, looking for cells, tumor cells, which are shed in that, and coming to a diagnosis rather than taking a biopsy sample from the specimen. Anti-cyclic-8 antibody is useful in eosinophilic gastritis and duodenitis. There has been papers regarding etazolizumab and combination with bevacizumab in patients with HCC, IM Brave trial, semaglutide for NASH, and combitolimab, or which is a DNA-based oligonucleotide that activates TL receptor 9, which is given as rectal enema for left-sided UC. All these are some recent updates in the field, and I think like it is better that you need to you know at least the names of these things. Maybe 7 guidelines has been recently updated, and I think like it is a must read for postgraduates preparing for exam. And these are some other papers which I would ask you to go through. With that, I conclude. I'm sorry for the technical glitches and taking going a bit longer than expected. Thank you so much.
Thank you, Dr. Sojan, for the wonderful coverage of almost everything. We have covered most of the newer molecules. I am sure the postgraduates will immensely benefit with this, because short notes definitely come from newer molecules. One short note is expected. Last time it was tafasitamab. This time, any of these things Dr. Sojan discussed can come. Another short note which can come is artificial intelligence, either in the diagnosis or in endoscopy or in some algorithms in the management of ICU diseases, etc. So artificial intelligence, I am sure almost that's sure it's a question. It will be asked either in the viva or in the theory. Okay, that's sure. Okay, and all the new molecules, I think you have to have some stuff with you so that they can answer a short note. Okay, because of these new drugs are not much of literature, but still you must be able to answer a short note, or at least in Viva also sometimes some examiners will ask about all the recent drugs. So it was a great session. There were some doubts. One was about liquid biopsy, which you already covered. There was another doubt whether vedolizumab or infliximab, which is superior to perianal disease. For perianal, I think it is infliximab, which is superior to all the other drugs. So no doubt. Other question was about epigenetics and all. It was more of a generic one, and I think you may have to refer to those things. For gastric carcinoma, genetics, metabolism, all those things are there. I think it's in a Selsinger and other review articles, all those things are there. And it was a great session. Dr. Srividya, are you there? Dr.
Yes,
Srividya?
sir. Yes, sir.
Okay, for the vote of thanks. She is the PG coordinator.
Yes, sir. I would like to extend my.
Can we see you?
Sir, actually.
Okay, no problem.
Yes, sir. I would like to extend my sincere gratitude to Sojan sir. Actually, we are immensely benefited by this section. I'm sure that we'll perform more in our theory exam after this class. And I would also like to thank Varghese sir for supporting this class. And also I would like to thank Sun Sickness for their support. Thank you all.
Thank you very much, Sojan. Thank you once again from ISG side. Okay. Good night. And the record, it has been recorded and it will be available in this Facebook group after a couple of minutes. And anybody who would like to download it can download it. Okay, so Dr. Sojan has given complete permission for recording and downloading and reusing. Okay, so on the Facebook group, you can download it and use. With these words, I conclude. Thank you very much. Good night, all of you.
Thank you.